Welcome today to the Implementation Science Interest Group. We haven't had it for a couple of months, so it's good to sort of get back on board. So today we're going to be talking about context matters in implementation science. But first of all, we'll do the acknowledgement of country. So I acknowledge the traditional custodians of the Macquarie University land where we are today, the Wijekulasuriya clan of the Daru Nation, whose cultures and customs have nurtured and continue to nurture this land since the dream time. And we pay our respects to elders past, present, and future. Okay. So I'm just handing over to Shalini, who's just going to update us on the survey that we just had recently on the running of the group and some input.
Yes. So we did an evaluation survey in July. It had a few questions in it just to get an idea of what the ISIG members were thinking about the group and to get any feedback or suggestions. So 91%, so we had 22 people respond. So 91% said they were satisfied with the current format. So that's the monthly meetings over Zoom. The likelihood of recommending it to a friend was 7.8 out of 10. None of the responses to this question were below 5, and most of them were around the 8 mark. We also gathered how has the ISIG been useful to you? So it's great to see that a lot of people said that it improved knowledge of implementation theory and practice and raised awareness of others' research and or work. And there's a bit about engagement and making new connections. We also asked if the respondents had ever watched the recordings of the ISIG meetings on YouTube. So 68% said that they had, which is great to see. And they are all on the AIHI YouTube channel. And then we also asked about a jobs or opportunities bulletin. So if we got any sort of advertisements or notifications about conferences, jobs, whether or not members would want a bulletin. So about 64% said that they would, and that it should be around once a month. And then just onto the actual suggestions. So regarding the format, the main suggestions were to vary the day of the week that the meeting is on, more opportunities for discussion and networking, more links to resources and wider advertising. And then these were some suggestions for future meetings. So kind of discussions of specific projects and barriers associated with that, collaborations between implementation scientists and non-implementation scientists, discussion of various methodological approaches, also discussion of implementation fidelity, integrating implementation science into policy and how that relates to knowledge translation, equity, practicalities of implementing programs, and implementation science labs. So that's just a quick overview of how the survey went. The committee is definitely considering these suggestions and going through them, and we'll implement them in the future. And just to also flag, we have put together a committee email address. That's the centralized point of communication. So that's the email address on the screen. So it's isig.committee@mq.edu.au. So if there's ever any questions or suggestions or anything, feel free to email that email. That's it from me.
You're doing the Menti meeting.
Oh, yes. So before we get into today's presentation, we're going to go through a Mentimeter. So just bear with me while I share it. Okay. So for those that haven't used it before, there's a QR code or there's a QR code you can scan, or you can go to menti.com and enter into that code. And we would love to hear your responses to the questions that we're about to put on the screen. There we go. Okay, so the first question is, what are some contextual factors that are important for implementation projects? So we're getting a few responses already, which is great. So things like leadership, culture, readiness, geographic locations, prior experience, organizational goals, which is the important one, resources. There's also maturity, climate, existing strengths. Scale and speed.
Okay, we've got, yeah, that's great.
So those are, yeah, so a lot to do with culture, maturity, leadership. We might go on to the next one. We have 4 questions for you. The next one is an agree, disagree question. So the quote is, context is everything else that is not the intervention. Do you agree with this statement? So it's a bit split at the moment, which I guess we can discuss later.
It's not surprising it's split.
Yes. It's a bit of a random thing.
Yeah, considering the lack of definition.
Yeah.
I'm not surprised.
I just wait for a few more people. I think people are still.
It's very interesting, that one.
Yeah, so basically 50-50 at this point.
Literally.
Yeah.
Okay, we might go on to the next one. So the next one is, do you feel context monitoring is essential throughout the project? Yes, no, or unsure? That's very quick. Everyone's just putting yes.
Yeah, a bit more consensus there.
Yes, definitely.
Very,
yeah.
everyone was very definite.
Yeah.
All right. That one, I think, very clear.
Yeah.
All right, and this is the last one. So this is another open response. So which implementation models and frameworks have you used that include context, constructs, or domains?
That we used or that we know of?
Maybe used or know of? Lots of TDF.
I'm just writing them all separately.
Yeah.
So there's like 3.
There is fairly, yeah. Very interesting.
Process models.
Okay. Wonderful.
Excellent.
Thank you very much for that. That's great.
We will stop that and I'll hand it back to Karen.
Are we using any more?
No, that's it.
No, that's it for the mentee today.
Sorry, I'm just finding my slides. Can everybody see that?
Yeah, this is what it looks like on the Zoom, so. it's
Okay,
there.
all right.
Perfect.
This is hide presenter view. I am not getting any presenter view.
Neither are we.
No,
on Zoom.
no. There's bars in the middle of my there we go. Okay. Oh, there we go. So this is again, we were just wanting to sort of see what people thought to start with. We just thought we'd do a little Menti to get people started on this, get their head into the topic for today. So I'm just having, do I have to change it on your, oh no, there we go. Okay, so so there was a couple of definitions. Oh, hello.
No, it's okay. You keep going. Just keep going.
Sorry.
All right, okay. All right, okay.
We're seeing
Right,
okay. Yeah.
I got it.
Sorry, we just have another technical issue. But so the Nilsson paper that we shared with you, so within that, it said for implementation research, context is the set of circumstances or unique factors that surround a particular implementation effort. And then Rogers is actually did another scoping review, and this is their definition that they came out. This was in 2020. So it's defined as a multi-dimensional construct encompassing micro, meso, and macro level determinants that are pre-existing, dynamic, emergent throughout the implementation process. And these factors are inextricably, I can't say that word, intertwined, incorporating multi-level contexts such as culture, leadership, and the availability of resources. So this came from a scoping review that they pulled, and they were looking at all trying to find a definition of context, which does seem to vary in a lot of the literature. And I just wondered what people thought of that, and we can sort of maybe discuss if it does. It seems to be quite a detailed definition, but as you go through many papers, they're very different, and it depends if it's in the education sort of learning sector, organizational. It depends which context they're talking about. It does vary, but this one was trying to encompass it all. So going back to the paper that we shared. So understanding what happens when evidence-based practice, and we all know what that is woven together with a team, department, or organization is important to address implementation challenges in healthcare and other contexts and other settings. Context is considered responsible for study-to-study variations in outcomes. And we're all aware, and I noticed the different frameworks that we were talking that people highlighted in the Mentimeter, is that the context isn't always used. The word isn't used. So it could be setting, environment. So it does interchange, but the meaning in most of the research is the same as context. So of course, we've got the inner context, the micro and meso levels, and then the outer context. So different frameworks use inner and outer. Some, talk more about the different levels. But as we are very aware, the line between these contexts is often really blurred and lacks clarity. So when you're trying to look at some of these frameworks and working out which context they go into, it can actually be quite difficult because there is so much lack of clarity exactly which one fits and where. But I think one of the things that they did highlight, which I do find in the research that we've been doing, is timing of implementation is not always considered, because you get money, the projects start, you've got to get the project started, but the preparation time is not often considered, and the organizational readiness. So, we know that a lot of health systems are going through changes, and sometimes the timing is not the right one. And many healthcare professionals are feeling rather overwhelmed with the amount of change that's going on. So I think I definitely agreed with that, but it isn't always considered in implementation. But happy to discuss more. So the different, in the paper, they talk about the different contextual determinants. So we've got, it's important to identify the key determinants that influence implementation. So these are some of them, but there are, you know, other ones as well, but it's really honing into what ones are relevant to your implementation study. So there's organizational support, financial resources, again, social relationships, leadership. And these are some of the things that you highlighted as well: organizational culture and climate. I noticed culture was quite, it was quite large, I think, in that word cloud that we did, and patient-related determinants. So to go into a bit more depth, so organizational support, I've just summarized what I pulled out from the paper. So various types of administration, technological and human resources for success. So that's that planning and organization of staff training and information and decision-making support systems. And I think that was interesting what Trish Greenhalgh said today for some of those that were at the presentation we've just had. And that decision-making support systems are often not embedded into the system. So that can make it either quite clunky and inefficient. And it's also associated with attitudes and the use of the evidence-based practice. And then it also can be a way of mediating between private and public systems, which it can be, but we have found that there are quite a lot of barriers, or, you know, the very large walls between the different systems. So there's financial resources, the economic means to support and enable implementation of change in healthcare practice. So the funding, reimbursement, incentives, rewards, costs, but the lack of resources can be a barrier to implementation. And we have found in one of our studies, for example, that it's a project funded implementation of a model of care. But, you know, some healthcare professionals have chosen maybe not to refer to that care coordinator because it's time limited, and they don't want people, you know, engaging with a service that they don't know is going to be ongoing. So that can be a bit of a barrier. Social relationships, and I know a lot of time and effort can be taken up. And this is really important in developing those relationships, working out how to communicate with each other as well. It's very much impacted by attitudes, the behaviors of different people, who they, so we have got some people where there's that power imbalance, and that can often happen in health as well. So we're talking about, you know, those relationships can help to make or break some of the evidence-based practices that are being implemented. Organizational culture. So we're, you know, looking at it from a varied position. So the professions, departments, the teams, and then we've got the different professional cultures and values in there as well, and sort of the different beliefs and behaviors that people can really influence the way the project, or, you know, the implementation goes. And the staff can, you know, have their own perceptions of the impact of their work environment as well. So so that can be very much be part of the whole picture. Leadership. Now, I think this is really important. It can be informal and formal leaders who can influence others. And you know, you see this. There are, and I suppose then we can maybe call, you know, some of them as champions, but they can really guide and inform the research. And leadership is concerned with the settings, you know, direction for the change, developing that future vision, that, you know, involved in planning, budgeting, and coordination. And so that this can be a real make or break situation. So contextual determinants, so the patient-related ones, and I think this is really important that we have the people that are going to receive the intervention or be part of it, you know, or involved in it, that we actually hear from them, and because they can actually help to improve health outcomes and the quality of care through, you know, being part of the decision making, their engagement and their involvement. And they can, you know, that peer support, bringing other people into the program as well. So just a bit of an overview. It's important that researchers are aware how context is defined or interpreted in the studies, which context dimensions are considered, and why these dimensions might be relevant. And context, as I've already highlighted, is generally not described consistently. I think it's really important if you are, you actually define what your context is, and how you define it when you are maybe engaging in your research. There's inconsistency with regard to which determinants are addressed. So not all of them are addressed in all projects. And the challenge for the research is to identify the most important context dimensions and address these in the research, develop more consistent terminology and advance role of context in implementation science. It does seem that that is a common theme through most of the research, is that we need to raise context in the implementation science world. So we did the Mentimeter, and it was quite interesting because these are the context measures that Rogers identified in their systematic review on defining and assessing context in healthcare, and the Paris framework topped their review, and then the TDF. So I think the TDF probably was one of the most common ones in the Mentimeter that we identified. Sorry. Yeah, I think it's because it's got quantitative measures and qualitative measures. So they might have used the it in surveys. They sort of used that as a framework. So I thought that was quite interesting, because that's why it was really good to see what other people were thinking. So, you know, planning for implementation and ongoing evaluation and monitoring is important for context. It highlights the importance of context, sorry. So I don't know if people, I haven't actually used these, but these are some frameworks or, you know, guides to assessing context, that this is the Centre for Implementation, So they've got an actual, this is an abridged version, and they've got an actual more detailed version, but I just thought this might be just good to look at the different points that we can discuss. So in the initial considerations, what are the reasons and motivations to adapting the thing, as we all should, you know, are aware the thing is the intervention. What systems and implementation factors affect the fit, and then what are the factors that affect compatibility of the thing? And then we've got the readiness. What are the system or implementation factors that affect readiness? What are the capacities are necessary? And then evaluation. And this is an area that often is forgotten in the planning, and I know I've sort of been part of a few projects, just, you know, sort of more the smaller ones, and sometimes the evaluation and looking at sustainability right at the beginning is not really addressed sometimes very well. And this one was another tool that was identified as that some people use. And again, it sort of helps to, you know, this is what you do, the exploratory stage, to determine the intervention fit with the local context. And then later stage to diagnose context challenges. And I think that's really interesting, is actually looking at why there's been some issues along the way. So this is, there's the need, so there's different colors, as you can see. So they're looking at different components of the planning. Okay, so So just in summary, it's the way that context is defined or interpreted can be, what is relevant to your study. And the challenge for the research is to identify the most important context dimensions and address these in their research. And that context is not merely a passive backdrop to implementation. And I think that's, I think that's really important. And I'm sure most of us know that here, but it's really good. I think there is that perception that context is what's going on in the background. So I just wanted to highlight this. So this is a project that Yvonne and I are involved in, which is called Rural Kids Guided Personalised Service, which is a care coordination service for children with medical complexity living in rural areas. And it's just good to just get a bit of an idea. There's different colours because these are the different people that are very much involved with the care coordinator programme, and it's been implemented in 4 local health districts. It's based on a model that was developed in the tertiary centre and has been adapted to rural and regional context. So we've got the tertiary hospital and specialist multidisciplinary teams, and they've also got their own care coordinator within there. Then we've got the local hospital and teams, so they're the green. And then we've got the family, and it's very much, we need to understand the family situation, whereabout they live within that LHD, and the communication methods that they are able to use, because that again has been, that technological literacy has been, for some people, been quite challenging. So it's not always having access to the technology, it actually can be how to use that technology as well. And then we've got a wide range of services here that people engage with, the families engage with. And then we've also got, and because of the geographical location, we've also got the travel, accommodation and needs, and how the care coordinator has to be able to navigate that as well to get them to the right care at the right time. And for some children, it may take a whole team to actually get them to their appointment. So we've got, a paediatrician very much highlighted that I should read the UN commitment on the every child has a right to health care. He thought that would be a nice bit of light reading for me. And then we've got, complex children, and we have got some psychosocial family challenges. We've got staff changes and shortages. We know that that's a big issue in rural and regional areas. We've got limited resources, services available. We've got complex health and social systems to navigate. We've got passionate, committed, resourceful care coordinators, which are amazing, who can adapt and flex to all the different challenges that they're faced with. We've got time-limited funding. We've got COVID-19 floods and fires in a backdrop of all of this. And then we've got limited access to EMR with the LHD across LHDs. And then we've got NDIS complexity. And yes, it is medical complexity that we're focusing on, but a lot of the children have NDIS funding, which then adds another complexity to navigating care and support. And we've got local LHD and New South Wales health reforms going on as well, and cross-border challenges, which have been highlighted as a huge issue for children that might even live very close to the border, say, for example, in southern New South Wales, but to the border of ACT, but might actually have to go get their care at Goulburn Hospital, because even though they're close, they can't go across they can't go across that border. And then we've got relationship building with families, local and tertiary teams. So there are many people involved in this whole project. that we need to consider. So, on that note, Yvonne is going to share some insights from the other paper that we shared with everyone on the suicide prevention in regional Australia. So Yvonne has also been part of this other Rural Kids, but she's going to share the insights from this project.
Thanks, Karen. And both of these projects are fairly complex, lots of moving parts, lots of different partners. And as you all know, implementation in the health system is complicated and complex as well. So this particular study, we partnered with the Black Dog Institute, and they had started their lifespan suicide prevention intervention implementation. The intervention was very complex, so there were 9 different strategies embedded within the lifespan intervention, and the intervention spanned community as well as health services. So it was kind of a whole of community approach, but it involved EDs and LHDs and primary health networks, as well as local services, councils, etc. It was implemented across 4 sites, different sites to the ones that Karen just talked about. But there was one site that was considered metropolitan, although it's a regional city, it's not Sydney. And there were also sites in rural regions. It was really interesting coming into this project fairly late on. So we were brought in to do the implementation evaluation some way into the project. So the project was almost finishing up, which is not ideal. So we had, limited opportunity to influence how the implementation happened and what data were collected to inform the evaluation. And unfortunately, this is often how these projects happen. People do, and they want to make change, and so they go ahead and implement without necessarily thinking through very carefully as to what sort of data they need to collect in order to understand what's happening. Karen mentioned leadership. There were leadership issues in this as well. So in some of the sites, the leadership that wanted this program in their LHD then left, which created sort of a power vacuum. And it was very difficult for the coordinators who were coordinating these collaborative groups that included all kinds of different community groups to then have legitimacy to actually be able to implement. The governance structures that were in the different sites were also different. They differed and their approaches differed. So, for instance, there was one site where the coordinator was based in a PHN, and the PHN's approach was very businesslike. They wanted to see KPIs, etc. The coordinator needed to make relationships and to make connections in order for this to work. And she was constantly being asked, what on earth are you doing? Why are you having coffee with everyone? Why aren't you meeting your KPIs? And so understanding the level of maturity that exists before you go into implement and doing some formative evaluation is really important. And that certainly wasn't done in this project to the extent that it should have been. And so some of the sites were quite mature. They already had a collaborative group that was working together and was quite effective, while in other sites that wasn't the case. And so in this study, Janet very ably demonstrated the growth of networks. So that networks grew, of course, but they grew more in the sites that were much more mature and had some strengths already. So I think that's all I need to say. I'd like to open it up for discussion, actually, and hear from other people about, you know, what you've experienced when implementing or evaluating, or yeah, and you know, how have you experienced different contexts, and what challenges and solutions have you come up with?
Is there anybody, we can't see everybody here, so if anybody would like to just unmute themselves and if they want to sort of add anything to the discussion. I just wanted to, just while we're waiting for people to think what they'd like to ask, I just wanted to add to Yvonne's discussion about the maturity of the different areas, because we've had that experience with the rural kids GPS. We've had some people that have had a care coordinator service for a few years, and then we've had some that have just come on board with the project funding. And and when Yvonne talked about sort of that evaluation and, you know, looking at before implementing, the cross-border challenges are definitely something the care coordinators have had to develop sort of workarounds to actually be able to communicate, and who they can communicate with, some bypassing some of the restrictions that they've had in accessing information in a timely manner has been quite challenging. But they've done really well with how they've had to do it, but it has taken a lot of time, and this is all the time eating into the project while they've been doing all of this. Yes, Mila, I can see you've got your hand up.
Hi everyone, thank you for the wonderful presentations. I've absolutely enjoyed every aspect of it. It's going to be a bit of a long one, I guess. It's possibly a question for Yvonne. So my PhD was around evaluating implementation fidelity in healthcare settings. And the topics we discussed today, the context, the program evaluation, the process evaluation, are kind of aligned, because through my systematic reviews, it showed me that a component of fidelity, the context, is one component that should be formally assessed. And the challenge is, as you say, Yvonne, is we often asked to do that at the end rather than beforehand. So I guess the question is, in terms of, you spoke about formative evaluations beforehand. The value is not placed on that. So how do we go and measure relationships? Because it's such a perceptional and behavioral aspect that in healthcare that's quantitatively dominated is really hard to do, really hard to tell people why it's valuable, and then really hard to perhaps put it in a positivist view that, you know, it's a single reality that we must adhere to, rather than that multiple realities exist and that people construct meaning and culture and behaviors around what the context is. So yeah, I'll be here to keen to hear your thoughts on that. Thank you.
So I agree, Mila. It's really difficult, isn't it? Because a lot of people in health come from the RCT sort of paradigm, and they expect everything to be controlled and nice and neat, and fidelity to be, you know, the same across sites, and that just doesn't happen. That's not reality. The other thing that is really difficult in healthcare is that no one pays you for formative evaluation. It's hard to get money to do that well. People want you to implement and make change. Thank you for the thumbs up, Christy. That's certainly been my experience, and I'm hoping that you know, we change that, because we could actually be throwing good money in after bad if we don't really understand those contexts before we start. I'm not sure what else you asked me now, Mila.
I asked, so that was the context, you know, if there is a formative way we can measure that, but in relation to what you just said in terms of fidelity, I guess people do see the value. So, you know, the process evaluation of complex intervention by the Medical Research Council in UK has context as its core component that should be measured, but nobody tells you how it's done. And in implementation science, we have fidelity frameworks that kind of are all over the place. And then we have behavioral science and so on. So it's really, I guess, and then you
Yeah.
come to implementation practice and people just say, I just want to change practice, and it's the
Yeah,
hardest
that's
thing to
right.
do. So I guess in terms of bringing a structured or a scientific approach to that, what
Yeah.
are some of the steps, given the complexities, particularly the system level? You have all those moving parts. How do we make sense of a chaos that at least we give the intervention the best possible chance of succeeding in that
Yeah.
chaos?
So using frameworks that include that sort of complex adaptive system approach are really helpful. Understanding what the core components are and having a really good understanding before we start, and understanding how that works within each of the sites that we're working with. But also, it is an adaptive system and things change all the time. We need to be monitoring context. So, for example, monitoring and also having mitigation strategies. So, for example, relying on one person to lead the implementation in a site is risky, because if that person becomes ill or leaves their position, you have that power vacuum, as I said. So actually monitoring it, and how you do it, well, there's lots of different frameworks out there, but essentially it takes usually some kind of mixed methods approach. And, putting in some formative evaluation feedback loops is really good way of doing it, so that you're actually monitoring what's happening, on a regular basis, rather than waiting to the end to then realize, oh, well, that context in that site was completely different to that context in the other site. And that actually breeds, unhappiness among the sites, because they're seen as different, and they're seen, maybe the ones that were not as mature are seen as not performing as well, but of course they couldn't. So having that sort of, understanding and feedback about what's happening is really important.
It's almost like it's a science is a team sport, so it's very much the one person heads everything along gone when it comes to implementation science. So it's like a network and a connection of people with different skills that can bounce off each other so that they can collectively grow, from what you're saying.
Absolutely. And that sort of network analysis that Janet did for us in that paper that we shared with you is actually a really nice way of demonstrating that to those in the health system, because it's a visual thing. You can see what's happening, and they tend to engage with that.
Thank you. Michael, I notice you've got your hand up. Would you like to unmute? Thank you.
Yeah, look, just a quick comment. Well, first of all, thank you for the presentation. I think it's been great, and thanks for the invite. Look, I think the couple of things that you noticed, or in terms of the experience of implementation itself, I think when we look at where there have been good success in implementation, it's where people are really aware of what the problem was, have participated in really understanding the problem, and have participated in identifying the root causes, and then arrived at solutions before implementation commences. To Karen's point earlier, the way it happens in health, and a lot of times, is the problem definition and the solution and the root causes are kind of done in a separate team, sit somewhere, maybe in some ivory tower, and then the root causes are identified and the solution is then presented for implementation. Now, in such context, what my experience has been is that when we bring to the implementing sites the background story of this is a problem, and this is now part of the challenge is actually identifying those documents. Part of the challenge is knowing where they are, who to ask, find out what is the problem that they're trying to fix, and then when you present that information to the teams who are really participating, then they kind of get it, and then you get the variations, and then you really can kind of take small steps, and and therefore the time lost between, you know, from a team's perspective, you know, how they go through the forming, storming, norming, performing kind of thing, you can pretty quickly get into performing stage once we get them the evidence and the reasons why we're doing what we have been asked to do. So I think in the absence of formative evaluations, when we're actually working with teams, when we bring these why we have to do it story along with the sponsorship and everything around implementation science, if we bring that to the context, I've noticed things are a bit more it's not easier, but a bit more manageable, working more, a bit more quicker. Yeah.
I think they're really good points, Michael, and very insightful. You're obviously within the system, so you know how it works. And I think, you know, some of the things that you've talked about point to, you know, the key ingredients for success. And what you're talking about is co-design and engagement and buy-in and ownership. And that needs to happen from the beginning.
Correct.
And I think if we look at the, you know, the kids GPS program that was implemented way back in 2016, that is exactly what they did. And I think that was part of the success that they've had, and the fact that they've sustained it until now is, you know, is due to that initial work that was done at the beginning. Okay, there's a question here. What happens when we measure readiness and the setting context is not ready? Critical factors are missing for successful progress. Karen, do you want to take that one?
Well, I find that really interesting that that's been brought up, because I've been doing the implementation evaluation, and one of the LHDs, when I spoke to one of the managers, because we'd had some challenges with this particular LHD. It's not that they didn't want the program, but there just seemed to be a bit of problems just with the buy-in from the bigger organization. And when I spoke to the manager, she said, "Oh, we have been going through a 5-year LHD reform." And she said, "We are all exhausted. We have had so many changes." And it just really, and I thought, well, that's really interesting, because we've just implemented this model of care into this system that is already feeling, you know, that they're overwhelmed and that they've had so many changes, and they were just going, "Oh, here we go, another one." and they didn't really embrace it. But to be on a very positive side, they have actually just won the award for that LHD for this model of care that has been implemented. So it was very challenging at the beginning, and we all kept thinking that there's just seems to be issues within this LHD, but they have proven their worth. And they've made so much changes, and people are really starting to engage in the service. And I've got people going, you know, we don't want to lose it. And the families have really been engaging in there. So although we didn't have time to sort of, with the project, the funding started now, this is when we had to implement it. And, you know, that there wasn't any checking about the readiness at the time. But then, I mean, we were implementing post-COVID, and they just had huge fires as well. So, you know, there was a lot going on in that particular organization.
Thanks, Karen. If I could go to Angela, actually, and to others, measuring readiness. How do you guys do it? I mean, it's something that's really difficult to do. There's the Sirocco model. What have people used? Angela, do you want to comment?
Maybe not. Oh,
maybe not.
She's put in a comment. Oh, is that her comment?
That's her comment. Yeah. Have others assessed readiness for implementation, and how have you done it? So often it's a fairly informal process. And it's also intermixed with that engagement process at the beginning. As you're engaging in co-design, you check in, you know, what have you got? What can you do? That kind of thing.
But I mean, we did have some, you know, what we need to sort of check as well is you know, is that readiness, and also, as Yvonne mentioned, the maturity as well. I mean, the service that I'm talking about, that their LHD was going through lots of reforms. They also had funding previously for implementing this model, and then they didn't get it. There was no sustainability of the funding. So then this model was then reintroduced with this new bucket of funding. So they'd had a bit of a roller coaster ride as they went along as well. So I think that's something else to really understand. You know, these people had been involved in seeing a model that worked, but then the LHD not taking that on board. And I think that might have been part of all the reforms that were going on at the time too. Is there anybody else would like to make any comments? Any other comments, discussion points?
I just had a comment, because all of this makes me think a little bit about the implementation, and I suppose in the event that you find, I suppose in my experience, it's more been the situation of not having time to do the formative stuff, and then you find yourself in a situation where it's not working. And your evaluation might show that, but so I suppose to me that's almost the other flip side of this talk is you know, what do you do when the readiness isn't really there, but because of funding and timelines and everything, everybody's gone along and done it. Yeah, so that was maybe just a thought for future discussion, but just throwing it out there for now.
Yeah. And, you know, that sort of monitoring, cyclical monitoring, whether it's through PDSA cycles or formative feedback evaluation loops, is really important to adjust the model. It's highly unlikely that you would have developed a model that is absolutely perfect with the perfect fit for every site. And so adaptation is not a bad thing, because if it makes it work within that context, then that's a really valuable thing to have done, rather than waiting to the end and then saying, oh, well, it didn't work, so, you know, we're throwing the baby out with the bathwater.
The name of the official ADCAR. Michael's mentioned ADCAR as a tool that they've used on level of awareness, acceptance, capacity, sponsorship, knowledge are all tested.
Yeah, I mean, I think there's, I mean, we've done ADCAR, but we've done other similar tools as well, because ADCAR is very prosky. But the other ones, I can't remember the name of the tool. If I do, I'll send across.
Yeah, no, that would be great. That'd be great. Thank you, Michael. Is there anybody else I want to contribute to the discussion? Any questions, any comments, any experiences of their own research?
Hi there, it's Angela Melder here. Can you hear me?
Oh yes, hi Angela.
Oh,
Yeah,
sorry, I got a phone call just as you were discussing things, and I suspect my question came up, so I won't go over all ground. Where do you think concepts of equity come into it? Is that a context concept?
yes.
And then history when you're working with Indigenous communities, which, and indeed any community, we all have history, but is that a context concept, or is that too big an issue, or is it different?
Yeah, that's come up in a lot of interviews, especially with the healthcare professionals in this evaluation, that, you know, healthcare, that it needs to be inequitable to be equitable, you know, so that those people that can't access care or aren't able to you know, they've got no transport, they've got financial issues, and this is this is just fresh in my mind. I was sort of reviewing a interview from one of the pediatricians, and he was saying that it takes a whole team, and he was talking about Indigenous families to actually get the child to the appointment, and it might mean lots of people are involved in getting them there, but they are the people that really benefit from this care coordination service, because otherwise that child would not be getting the care that they need, and they can't access private healthcare, or, you know, so there's no alternatives. This is so that, yeah, what you bring up, Angela, is something that's really come through in the discussions, because unfortunately they're the population group that I haven't been able to interview. So I have to get the stories from the healthcare professionals to actually hear of the challenges and how they actually access healthcare, and how much, like, the care coordinator service has actually helped support these families to, you know, for the child to get the healthcare that they need. But they probably use the care coordinators much more than other population groups. Yeah.
Thank you. That makes sense, and I can understand that. Yeah.
Yeah. Well, I think sort of, if there's no more discussions, I've just noticed it's 1:30, so thank you very much, everybody, for coming. We've got our next meeting at the end of November. That'll be the last one for this year, and we've got Perrin Moss, who's going to come and present to us on the ECO program. So we'll look forward to seeing you then, and we will hopefully start maybe sharing some of the information or any presentations that people are or any jobs or anything that people might be interested in. So I'm just taking on the feedback from the survey, then we will sort of start to distribute. So if you look out for that ISIG.committee email address that was at the beginning, that will be coming through that platform. Thank you very much. Thank you. Thanks very much for coming. Bye.